So I'm going to introduce the first speaker here. Born in the United Kingdom, Dr. Perry Kendall completed his undergraduate medical training at University College Hospital Medical School in 1968 and interned at Siemens Hospital in Greenwich, spending a year at the University Hospital in Kingston, Jamaica after that. And in 1972, he moved to Toronto and spent 2 years working in general practice at the Toronto Hassle-Free Clinic, and many of you will know that clinic. In 1994, he moved to Vancouver and worked for the Vancouver Health Department at the Pine Free Clinic on 4th Avenue, and many of you will know that clinic, which the government is just about to close, I see. In 1984, he returned to Ontario and was manager, disease control and epidemiology services at the Ontario Ministry of Health until 1987, when he returned to British Columbia as the medical health officer for the Capital Regional District. In 1989, he took on the role of the medical health officer for the City of Toronto, during which time he established harm reduction as the official city policy for substance use. And in 1995, in 1999, Dr. Kendall assumed the position of the Provincial Health Officer for the province of British Columbia. And a few things around what the Health Act says about the role of the Provincial Health Officer here. Advising the Minister and the senior members of the Ministry of Health on issues which may need legislation, policies and practice in health. Monitoring the health of the people of BC. Providing information and analysis on health issues. And reporting to the public on health issues that may need legislation or change or policy, new policies. And that is what we see in the work of, I guess, the new report, really, of Dr. Kendall, and that's what he's going to present on today.
Thank you. Am I close enough to the mic? Can anybody not? Yeah, that's a stupid question. If you can't hear me, you won't be able to let me know. Anyway, but thank you anyway. So, I move the arrows here, do I? To move them along? Yes, great. So thank you. So part of my role, as Rick said, is producing reports, and the annual report has to go to the Minister, then it has to be laid before all the members of the House, so they have to pay some attention to it. And this report actually looked at the human immunodeficiency virus epidemic in BC with a focus on gay and bisexual men for a number of reasons, which we will point out later on. Partly, and most importantly, they make up the majority of new HIV diagnoses in BC, and there's really been no meaningful decrease in incidence in the past 10 years. And this report was developed, essentially, its prime author is here, Dr. Mark Gilbert, who's sitting down over there, with a couple of advisory committees, including gay and bisexual men and related service providers and organizations. And if you look at trends in new HIV diagnoses in BC, the purple line shows a very clear decrease, and most of that is actually happening in people who use drugs by injection. Whereas if you look at the lower line, it's been pretty stable for the last 10 years, with maybe some slight decline, but nothing really nearly as significant as the decline in other populations. And if you look at the proportion of the caseload, both incident and prevalent, it's obvious that gay and bisexual men are overrepresented. They're 57% of all known new infections and 45% of all people known to be living with HIV in BC. And if we look at the prevalence among gay and bisexual men by age, you'd have to actually read this from right to left as opposed to left to right, which would be the standard way of doing it. You can see increasing prevalence by age from 7% in the young men under 30, rising to 34% in the ages 48 plus. And if we look at trends in new HIV diagnoses among gay and bisexual men, the highest proportion of new diagnoses are in Vancouver coastal health. So that means that 65% of all new diagnoses in Vancouver coastal are in gay and bisexual men, 37% in Fraser, 32% in interior, 30% in the island, and 7% in the north. And while on average Caucasian men made up the majority of new diagnoses, about 70%, we are seeing Asian men nearly 11%, Latino men 7%, and Aboriginal men at 4.6%. This is one of the few areas where actually Aboriginal men aren't overrepresented in the statistics. And those, and at least in 2012, those in the age group 30 to 49 made up the largest proportion, just over half of all new diagnoses, followed by those under age 30 and those aged 50 plus. And if we look at diagnoses by birth cohort, the green line is the one that's increasing, and that's in basically young men who were born between 1980 and 1999, but either they're 15 to 35 years old now. And you can see that increasing trend, which does suggest that if we don't redouble our efforts and find a way of addressing how or why HIV is being transmitted, this cohort will end up with the same relatively high prevalence as older cohorts in BC do have. So there are still opportunities to intervene. So some of the questions that have been asked is, why are HIV infections in gay and bisexual men not going down in BC? And there have been a number of theses put forward. They're not using condoms, condom fatigue, less concern about HIV given the fact that there are pills now, less perception of risk, less HIV testing. And we wanted to test all of these hypotheses out. But in fact, the issue is actually a lot more complex than any one simplistic theory, if you like, because we know that health outcomes don't happen in a vacuum. They're the result of complex interactions of a number of factors, many of which are determined by the environments in which boys and men live, work and play. And that was a quote from the medical officer of health in the Northern Health Authority, which I thought was really apt. And so with the help of the group and with Mark, we decided to look at the drivers of this epidemic. What is actually driving the ongoing epidemic of HIV in this community? And we took a conceptual approach, trying to be holistic about it, looking at 3 levels of analysis of the potential drivers of the epidemic, so societal and structural, communities and relationships, and then behavioral and biologic. And obviously they interact. No one set alone explains everything, but one set influences another and is in turn influenced by another. So we tried to use a population health approach looking at upstream factors. And looking at the overall drivers of the HIV epidemic, there are clearly biomechanical, biobehavioral drivers. The higher the prevalence in a community, the more likely somebody will meet HIV, for example. Sexual behaviors, treatment, what's the impact of treatment on viral loads? HIV testing and awareness, STIs, sexual networks, appropriate health care, stigma, poor social supports, a lot of factors that we tried to look at in this report. We didn't delve deeply into any of them, and this presentation doesn't have a chance of doing that in the time that I have, but I'll try and touch on all of them to some degree anyway. So obviously, with advances in treatment, people are living longer with HIV and they have a near normal life expectancy. So the net effect of that, because if you like, the pool of HIV positive men is going up, you could increase your chances of meeting somebody who has HIV and has maybe stopped taking their pills for a while, and so their viral load has gone up. And what we need to recognize, I think, as a fundamental piece is that positive prevention is a concept that recognizes that HIV positive men will have to play a central role in HIV prevention. And involving and engaging has got to be a key component to any HIV prevention strategy. So, are gay men wildly promiscuous? And actually looking at condom usage, for example, and risk-taking behaviors, generally, gay and bisexual men are actually more responsible than their heterosexual counterparts when it comes to condom usage on a regular basis, although there are clearly a percentage who don't, and casual sex partners, etc. And perhaps in this milieu, just that amount is enough to have ongoing risk encountered. And then we do know that there are still ongoing risk behaviours. They haven't changed much over the years that we've been looking at them, since 2007 to 2011. Between 1 in 4 and about 1 in 3 men had sex without using a condom with at least one partner. And about 1 in 4 to, again, 1 in 3 have 10 or more sex partners in the previous year, both of which we know are associated with risk of acquisition. And then when we look at the sort of biological risk, depending on the nature of the sexual encounter, the risk increases. And obviously, the highest risk is from insertive sexual, receptive sexual anal intercourse. And there's a range of risks associated with that depending on the study you look at. And there's obviously huge methodological difficulties in trying to come up with an accurate assessment of what that risk might be. But I think it's pretty clear it is the highest risk behavior. And then when we look at acquisition risk against viral load, if your viral load is suppressed, the risk is 0. Which is where treatment as prevention comes in, which is a program that the ministry launched just over a year ago. And then the higher the viral load, obviously, the higher the risk of acquisition and transmission of the virus. What we do see, however, looking at the community, is that the number of people with high viral loads at the time of diagnosis has been decreasing. So we are seeing people being diagnosed earlier on in their infection, which is really critically important because it's estimated that a really significant number of infections come from a newly infected individual who has no knowledge that he is infected but has a very high viral load. A significant number of new infections come from that group. And when we look at acute HIV infection, as I said, up to 50% of people diagnosed with HIV acquired their infection from a partner who was in the acute stage of their infection. And in BC, gay and bisexual men are more likely than other groups to be diagnosed during the acute stage of their infection, which reflects, I think, the frequency of testing, repeat testing in this community. And we know as well that if you can diagnose HIV in the acute stage, subsequent behaviour changes and connection to treatment will result, it says may here, but it will result in substantial population benefits in preventing new infections. If we look at HIV testing and awareness, it's high in all populations, as we can see here. And in the birth cohorts, basically about 80% of gay and bisexual men have been tested for HIV in their lifetime. About half report testing in the past year, but rates are significantly lower outside of Vancouver. And there's a lot of more awareness and access to treatment and services within Vancouver than there are outside of it. It's estimated, I think, nationally that about 20% of HIV-positive gay and bisexual men are unaware of their infection. If we look at STIs, another theory was that gay men aren't taking precautions, and so it's unprotected sex, and that would be reflected in the prevalence or an increase of chlamydia or gonorrhea, and that clearly isn't the case. The two, the red and the green line, are gonorrhea and chlamydia infections, and you can see that that rate has been fairly steady over the past decade without increasing. The one STI that has increased in the grey bars is in fact syphilis. And our theory is that that results from serosorting, which is an HIV protective behavior. Men who are positive go with men who are positive. But what this can do, and it's borne out by the fact that about 60% of the syphilis cases are also co-infected with HIV, is suggests that you have a very vulnerable population who, through serosorting and having safe sex that way, are actually driving in that small contingent the syphilis epidemic that we're seeing as well, the syndemic of syphilis and HIV in gay and bisexual men. So when we look at access to appropriate health care, that's clearly important, A, for testing purposes, B, for health purposes, for getting treatments, etc. And this looks at the percentage of gay and bisexual men who are out to their primary care practitioner. And it's much higher in Vancouver. It's much lower outside of Vancouver. And obviously, if you can't be out to your physician, then you're not going to get the appropriate rapprochement, the appropriate care. Care is just not going to be accessible to you. And it can take, I think, on average, was it about 4 years, Mark, before somebody felt comfortable enough to come out to their physician? So in terms of accessing primary care, that's clearly a huge barrier. Then we also looked at stigma and marginalization. And gay and bisexual men do experience stigma and marginalization. That's not new to you, I'm sure. But it does potentially, as we'll show, have profound health impacts. And gay and bisexual men of all birth cohorts, but particularly men born since 1980, particularly reported high rates of verbal harassment and suicidality. And when I saw this, I was deeply disturbed, because I thought we had actually come a long way towards acceptance, towards being more open and accepting in the schools. And as you found, schools that are, quotes, what's the term, not tolerant, but yeah, tolerant, everybody is better off, not only gay and bisexual minority students, but the quotes normal, heterosexual or heteronormative students are actually happier and better off as well, have higher mental health. So we've got clearly a lot of work to do in that area. And then when you look at marginalization and poor mental health outcomes, in a number of areas of poor mental health outcomes, the more you feel marginalized or experience being discriminated against, the greater your chances of having a depression, anxiety, suicidality, or needing to seek help. And that itself drives some of the behaviors, because poor mental health outcomes have a dose-response relationship with sexual risk-taking behavior. So the more you feel stigmatized or marginalized against, and the worse your health outcome, the more likely you are to actually engage in risk behaviors. And that itself leads to poor outcomes. So our thesis is that you can't address HIV risk without addressing the issues of the mental health and marginalization and the socio-environmental context in which young men are growing up. And this is borne out by the fact that social supports is a strong protective factor. And it can be fostered by strong connections with gay communities, within gay communities, which is probably why Vancouver has some of the more positive outcomes for individuals, and outside of Vancouver doesn't. However, many gay and bisexual men in BC report not having someone to turn to for social support, and this is particularly true outside of Vancouver. So the role of community and building community and capacity and resilience is really critical. We also know from the surveys that migration and immigration and experience of racism have deleterious impacts. One survey of HIV-negative men at a testing clinic in Vancouver showed that many people had moved into Vancouver from outside, but the effects of mobility and entering strange new environments are often compounded by the traumatic forced migration, particularly for First Nations men, of residential schooling, foster care or adoptions. And then when gay and bisexual men come to BC from other countries, they don't necessarily find acceptance here. And the experience of racism is one that is mentioned by many gay and bisexual men from ethnocultural communities in BC. So they may not be accepted in their own community, but then they have a hard job getting accepted in the Vancouver communities as well. So there are also some very systematic and systemic challenges to HIV prevention. So if you look globally, the public health response to the HIV epidemic in this population has not sufficiently protected their health. Quite clearly, you can see that from the ongoing epidemic there. And there are inadequacies in both the scale and the effectiveness of interventions. So, for example, less than 7% of papers at the 2010 International AIDS Conference and 7% for the Canadian Association for HIV Research Conferences were actually focused on gay and bisexual men. And given that you make up the majority of incident and prevalent cases, that seems grossly disproportionate. And in 2011, less than 10% of the Canadian Institutes for Health Research grant budget was for HIV prevention targeting gay and bisexual men. So I think we need to push those numbers up. And to be most effective as well, I think HIV prevention programs for gay and bisexual men, and this I think is an evidence-based or almost evidence-based factum, need to be developed and implemented in partnership with, if not led by, community-based providers and organizations. So, in a summary, gay and bisexual men continue to be overrepresented in the epidemic in BC, and we need to reprioritize prevention interventions for this community, or these communities, because there's not one community. We need to take a much more holistic approach to gay and bisexual men versus just focusing on the behaviors. We need to acknowledge the basic impact and work to reduce stigma and marginalization for gay and bisexual men. And the strategies should be built on what we already have as successes. For example, the high condom usage, high awareness, high rates of testing, and work in partnerships with gay and bisexual communities, and be based on a better understanding of gay and bisexual men's sexual networks and how they change over time. And that, I think, is a big area for research and intervention. So the community groups came up with some or the advisory committees came up with some very comprehensive recommendations. They did highlight the need for additional emphasis on, it's just not one community, as I said, 6 communities of HIV-positive men, Aboriginal and Two-Spirited men, other ethnocultural minority men, young gay and bisexual men, men in suburban, rural and remote regions, and gay and bisexual men in very active sexual networks. And they recommended that we needed to ensure meaningful involvement using assets of a strengths-based approach to health promotion, incorporating online models of outreach and service delivery and links to regional services. And Mark, when he was at BC CDC, was actually instrumental in promoting some of those networks. And in addition to the regular or regular health services, need to improve overall reach and engagement from the existing services out and tailor services to the current epidemiology of the epidemic and considering differences by region over time. And that's starting to happen as we roll out the Stop HIV in different regions of BC. The advisory committee also, well, they made some very comprehensive recommendations. So at the policy level, at the behavioral network and biological factors, for community and relationship level, for recommending addressing societal and structural drivers, and around monitoring, evaluation and research. And my office, I endorsed all of the committee's recommendations, which are provided in full in the report and are well worth reading. But knowing government, it likes to focus sometimes on a smaller number of recommendations. So what I tried to do was take the big totality of the recommendations and kind of boil them down into some areas where there was already some movement, and it wouldn't be too impossible to see how incorporating that in what was already happening could actually achieve much of what we wanted, or at least maybe some of what we wanted, not maybe much, hopefully some, within programs that are already going. So, but one overarching one was that given that HIV, like other health outcomes, is the result of socio-political context, I recommended developing a comprehensive provincial health strategy for gay and bisexual men that addresses the drivers of poor health status across the board, which includes HIV. We have a women's health strategy. Why on earth can't we have a gay men's health strategy? I think it'd be. The deputy said, of course. Then he looked at the budget and the minister. Anyway, and then I also figured that ministers of health and education and regional health authorities, provincial education partners and other key stakeholders should collaborate on the development of a comprehensive sexual and reproductive health strategy for everybody that is actually inclusive of all gender and sexual identities, and integrate health promotion messaging that challenges stigma and fosters protective factors. We're doing a bit of that, but we could do a lot more, as Annie would say, and we would see good outcomes from it. So hopefully education and health can work on that. Also recommended that we have a Hope to Health framework, which is the treat and test framework across the board. And I think it really needs to expand and engage and bring in timely HIV and STI diagnosis and treatment for gay and bisexual men. Focus how do we incorporate that population, have them in that strategy. And then recommendation 4, within the Healthy Minds, Healthy People, which is a 10-year mental health and substance use program, how do we develop a better strategy to meet gay and bisexual men's healthcare needs related to mental health and substance use issues, and do it with that population? And that work is ongoing at the moment with Warren O'Brien, who some of you may know, who's actually got both of those strategies. He's got more than enough to do, but he has both of those strategies, and I'm sure he'd welcome help in that. Then recommendation 5 was geared particularly at the Attorney General's Department and Crown prosecutors, which is trying to address the issue of criminalisation of HIV transmission. And I think how to bring in the best evidence on transmission risks and make this a much more reasonable approach than it currently is. So we have a lot of concerns that the current approach in BC is driving people away from actually knowing their HIV status because they fear the risk of being prosecuted. And unfortunately, the Supreme Court of Canada decision that came out a couple of years ago didn't really help that. I mean, I've had lengthy interchanges, as have Voices of Positive Living and other groups, with attorneys general to try and get them to set out what is the public good in prosecution, because you have to consider two things before you lay a charge. One is you're going to get a conviction, and the other is there has to be some public good in this. And my argument with them has been, in the way they're currently going about it, there's no public good, but there's a lot of public harm. So we meet a definite, I did meet with them, I did get a face-to-face conversation, but so far it hasn't gone very far with that one. And then finally, the last recommendation was support and initiate more monitoring and research in this population, particularly geared to HIV transmission, and the broader strategies that would increase resistance and resilience and prevent HIV transmission. So thank you very much. That's a very quick overview.